of bacteria, which is the spirochete. And it looks like a snake, or it looks like a little coiled spring. The thing to remember with these guys, when we looked on a gram stain, and that was the stains that had the purple circles and the red rods, those bacteria are relatively large. The spirochete bacteria are teeny tiny. So even under oil, you don't really see these directly. They are a helically coiled gram-negative bacteria, and they have corkscrew materials, or motility. So they just sort of, swirl along. They are spread by direct contact. I mean, if you got a whole unit of blood that was infected, you probably would wind up with it. For the most part, rarely with needles, with infected needles. We never want to rule out the possibility, but for the most part, these are spread simply by contact with some sort of canker or sore. They can be spread congenitally during pregnancy. They do cross the placenta. They cause everything from a localized skin infection that may disseminate to other organs if left untreated. The nice thing about these guys is, for the most part, a nice shot of penicillin takes care of it. The organism is hard to isolate. We just really do not grow it. It doesn't like to grow for us. We basically are just doing serology testing. We look for the antibodies. The first of the diseases, and most common in this country, is Treponema palladium, or T. palladium. There are other subspecies, T. perteneum, T. caritium, but palladium is usually the one we see in this country. It is transmitted sexually or congenitally, and at one point, I don't know if we still hold the title, but at one point, the St. Louis area was #1 in the nation for syphilis. Thank you, put us on the map. We had a lovely.
We're #1.
We're #1, yeah, okay. Yeah, we had around, we would get positives pretty much every week. It just was quite rampant in the area. I think they finally got it under control. I don't know who's #1 anymore, but it could still be us. It comes in basically 4 stages: primary, secondary, latent, and then tertiary. The primary stages is obviously at first, it's usually skin infection, something like that. Secondary is when it spreads a little further. Latent, it kind of goes to sleep for a while. And when we hit tertiary syphilis, hopefully by here, you're getting some penicillin. We shouldn't be waiting till here, but before we knew what it was and before we had penicillin, it killed a lot of people. If I remember right, this is what killed Al Capone and why he went batshit crazy, because it gets into your brain. It's not good for you. So the primary stage, we get a canker. Yes? Third. Primary is first, secondary is second, and tertiary is third. Yeah. And then we slide that sleeping stage in. The lesion called a canker, it's frequently painless. It's not, from what I understand, I wouldn't know, but from what I understand, it's fairly painless, but it's itchy, a little annoying. It usually develops a week, couple of months, after you're exposed. It's going to be on the genitalia because that's where most commonly this is spread through. It usually lasts for about a month, and then it goes away. So if you don't get worried by things growing down there, it'll heal up and you'll think you're all better, yeah.
Can it be on your mouth?
Yes. Yes. It can be anywhere, and on infants, when it's passed congenitally, we will see them in a variety of places. Faces, arms, wherever, yeah. But it's where contact occurs, and so that's generally why we see it there. But yes, it can be in other areas. If it goes untreated, like I said, if you don't worry about lesions and things down there. Or you don't notice it, I guess. If left untreated, about 25% are gonna go to the secondary stage. About 75% of the time, your body just flat out fights it off. It's going to go into systemic dissemination. In other words, it's gonna start infecting other places. You're going to see kind of a flu-like symptoms with enlarged lymph nodes, really tired, fever, often pharyngitis accompanies it. You're going to see a rash on the palm of the hands and the soles of the feet. It can involve the central nervous system in about 40% of the patients. You have visual problems, you can't see right, hearing loss, ringing in the ears, or facial weakness. These are all things that can happen if those spirochetes start affecting our nervous system.
Are those permanent side effects?
I don't think so. I'm not 100% sure. I know some of it can be reversed, not all of it.
40% just sounds like a lot.
Yeah, well, it's about half the patients who have it.
Right.
They have some sort of central nervous. Well, the nervous system, it's got all kinds of yummy. It's a warm, sweet place to live. There's not all those pesky complements and other stuff in your spinal fluid. So, nice place to set up residence. Basically, what happens in the latent stage, you don't have really any clinical symptoms. It's what we call subclinical. So your body, once again, is able to fight it off, but it's still hanging around, just not causing a lot of problems. At this stage, you are not infectious except congenitally. Okay, so it can cross the placenta still and infect the baby, but you cannot infect other adults or other people that you come in contact with. Tertiary, only about a third of those who are not treated move on to tertiary. It appears months or years after the secondary. Again, this is one of those things where your immune system's doing just great, keeps it sequestered, puts it in a bad neighborhood and leaves it there. You live over there, as long as you're not messing with anything, we're done with you. Then, unfortunately, what happens is your immune system drops for some reason. Frequently, it just age. Okay, as you age, your immune system becomes less effective. So what you're going to see is this is going to pop back up several months or even years after the secondary stage. 10 to 30 years later is not uncommon. You're going to see gumas. These are inflamed areas on the bones, the skins, or the tissue. They can heal with scarring, or they can remain open, festering wounds forever. Yeah, lovely stuff. In the 60s and 70s, especially, we saw kind of a rise in this in some older men, middle-aged to older men who maybe had been in Europe at the end of the Second World War. Yeah, we kind of had a little bit of a blip on the radar. It can lead to aortic cardiovascular problems, and it can lead to neurosyphilis. Acute meningitis is the form, and late tabes dorsalis, I have no idea what that is, I'll look it up. Degeneration of the lower spinal cord and progressive dementia.
Tabies is a bug that grows in the skin, isn't it?
Yeah, I think so. Congenital syphilis. This occurs when the woman has early syphilis or latent syphilis when she infects the baby. It most strongly affects the fetus during the second and the third trimester. Infants generally have no clinical symptoms at birth. They develop a couple weeks later. Well over half will become symptomatic. The first side of the disease is a necrotizing phalangitis, inflammation and dying off of the umbilical cord. It's kind of nasty. They'll have a clear or bloody runny nose, rash on the mouth, the palms of the hands and soles of the feet, similar symptoms as adult syphilis, and neurosyphilis can occur in as many as 60% of the infants. It doesn't have to go through primary, secondary, tertiary stages to get into the brain. It starts to affect them with pretty much primary infection. This is why we test every single female for syphilis.
Is that because the child's brain or bones haven't fused together, so it's a weaker barrier?
No, it's just because the child's immune system isn't ready to handle it. What do we look at for in a test? A direct antigen test is only positive in the canker. So in other words, the only time I can test for the antigen is if you actually have some sort of sore and the doctor actually scrapes it and we look for it. And as a matter of fact, a lot of times what we're going to do with that is a dark field direct examination. They're going to smear it on a slide. We're going to put some fluorescein labeled antibody on it, and then we're going to look at it under the microscope and see if we can't see the little critters. But we don't do this test very often. It's a very, very rare, because most of the time you don't catch it. And it is not positive a lot of the time. Unfortunately, when they scrape the canker, you got to get just the right gooey area, and it's much better to test for the antibodies for this one. All stages are positive for both non-treponemal antibodies, which is Reagin, and treponemal antibodies. What we're going to do is an RPR, a rapid Reagin test. And Reagin is a reactive chemical, a reactive protein that is not specific to syphilis, but is positive in something like 90% of syphilis cases. So this is a case where we're looking at a screening test. We do the Reagin screen because it's very cheap, very easy, and very sensitive. It is, however, not very specific. Approximately 20% of pregnant women are positive for Reagin with absolutely no relationship to syphilis whatsoever. And who are we screening? So one of the causes of false positives is the population that we're screening. So good screening test, not good as a confirmatory test. We then send it out for something further. Again, secondary stage is 100% positive for all test methods. If the patient's been treated, the non-treponemal test can go to negative, but they can persist pretty much forever. When you draw units off of a donor for autologous, that was a big thing in the 80s and 90s because AIDS, everyone was terrified they were going to get it, so they donate their own blood before surgery. And we would have to tag it if they had any kind of disease with it. We had little old lady, church-going lady, hat, little straw purse and everything. I mean, just sweetest little old plant. White hair, just cute little old lady. Hers was tagged positive RPR. And she was, I know, my husband brought it home from the war. So he obviously brought her a present from France. And she had to be treated for it. She had been treated for it back in the 40s, but she was still positive for the RPR, and this would have been in the 90s. So 50 years later, she was still positive. She did not have syphilis anymore, but she was still positive for the RPR. Many physicians begin with the non-treponemal test and confirm with the treponemal test. Good reason for it. Again, money. An RPR I think only costs like $8 to run. Super cheap. Okay, the FTA I think is $145 to run. And remember that's not what we charge. Charge has many other things built into it, but just that's cost per test to run it.
What type of test is it on an analyzer or is it?
No, we're gonna go do them. It's on a little card, and it's a charcoal. It's technically flocculation.
Do you do them at Memorial? Or
Not
do you send them
anymore.
out?
We actually did them up until 3 years ago, no, 2 years ago, and then there's a big push, you want everything on analyzers you can, because analyzers are cheaper to run than to have people time. So we got rid of them and went to a straight syphilis test.
So did that older lady have, you said she didn't have the disease anymore, why would you test it for her? Did she have
She was
symptoms?
giving a unit of blood, and we have to
Oh.
test every unit of blood that is drawn. Even if it's an autologous unit, it still has to go through
Mhm.
all of the testing.
So penicillin is a cure or just a treatment?
Cure.
It is a cure?
Cure.
I think, because I thought I remember in like high school or whatever, we learned that syphilis was like didn't have a cure.
It has a cure.
Okay.
Syphilis does. Many of the STDs do not, because many of them are viral. But syphilis can be cured. Now, it can fool you. So, and it's another one of those things, why do you take all of your antibiotics? Take all of your antibiotics, because if you don't, it'll become subclinical. It'll go into a latent stage where you don't know it's there, and it can pop back out to surprise you. But yes, it can be cured. It can be cured. Non-treponemal antibody tests. These are performed after the lesions have healed. We're looking for to detect reagent antibodies. And again, we're going to do these in lab today. I gotta go find all the stuff. They're a pain in the butt. They have more QC than any other test we do, but they're not overwhelmingly difficult. The treponemal antibody tests are going to be performed as a confirmation when the non-treponemal tests are positive. It directly looks for T palladium antibodies. The test that we switched to when we got rid of RPRs is chemiluminescence on the Centaur analyzer, and it directly tests for syphilis antibodies. So the thing with it is, instead of giving me a positive screening test, it's pretty much a positive, it's pretty much a confirmation test right away. So it's a little bit better. And a lot of things that were true even 10 or 15 years ago, methodologies are getting better, monoclonal antibodies are getting better, molecular diagnostics is getting better. So some of the stuff that we did way long ago, we don't do anymore. When we talk about viral antibodies, we're going to talk about mononucleosis. And we'll go through the rabbit and the beef and the horse and the guinea pig. We don't do those anymore. But they still put the blasted things on the bones. Direct antigen tests, dark field microscopy. We basically, the spirochetes are kind of a light color, and so we look against a dark background. And the main reason we have a problem with this is you pretty much got to scrape it off, put it on a slide, and get it under the scope fairly quickly. Otherwise, the little buggers are dead and they're not moving anymore, and we can't find them. It's sort of like trichomonas. Did you guys do trick in urines? The problem with trichomonas is that it dies off quickly. So if you can get a fresh specimen, you know, you get the little circus tricks that are in there dancing around going, hello, look at me, look at me, look at me, bouncing over here. And as it sort of sits there, they just sort of get tired and they just sort of wave at you. And fairly shortly, they just die off and they aren't moving at all. And you can't really call them when they're not moving. Direct fluorescence, this is the most common one we do. Basically, we put T palladium, we'll put treponema, we'll take the little spirochetes and smash them on the slide, and then we will add antibodies and look for, this is the direct fluorescence, where we take the patient specimen, put it on the slide, and use a labeled fluorescein antibody to see if we get fluorescence and see if they come up. Okay. These would be the direct antigen tests. These are not common. They're not common. The non-treponemal antibody test we use to screen for syphilis or to monitor treatment. Are you getting better? It's a flocculation test. It looks like an agglutination test, but it's more of mechanically it's more of a precipitation test. It's a precipitation that occurs over a narrow range of antigen concentrations. You've got a very fine charcoal, okay? And it will precipitate out and clump up if it's present. In the presence of reagin, which is an antibody-like molecule that reacts with lipids, okay, so when we have our reagent, we have to add a cardiolipin to it in order for our test to work. The reagin levels are highest during the secondary stage, and it can be actually missed during the primary stage. During the latent stages, a lot of times this will disappear or go down to very low levels. RPR is the rapid plasma reagin, and VDRL is the Venereal Disease Research Lab. This one, nobody does anymore, because this one, except on spinal fluid. We still do VDRLs on spinal fluid. They've got a PCR method out, so I have a feeling VDRL will become absolutely obsolete within just a couple of years. But we didn't do it, this one we do on a card with charcoal reagent, a cardiolipin charcoal reagent. We can see it, it's easy. This one, you actually had to mix them in a little well, a glass well. You had to have this perfectly cleaned glass, so every time you did it, you had to take the glassware, acid wash it, put it back together. If anything didn't fit exactly right, you had to take it apart again, rewash it, put it back together. Then you put it into these little glass wells and looked at it under the microscope. And if you weren't blind, by the time you got done looking at it, it was really hard to read. So it was a very fastidious test. It was very easy to screw it up. The RPR replaced it because, well, you can be crap-ass tech and sloppy. The RPR works just fine. It's a pretty easy test to do. Yes?
Is that the reagin you was talking about? You do for reagin screen for congenital?
Congenital. Mhm.
Congenital? Okay.
Rapid plasma reagin, we're going to use serum or plasma, usually serum. We're going to use a paper slide and add RPR antigen and put it on a rotator. The thing about doing RPRs is you have to, the rotator has to rotate exactly 100 RPMs a minute. Well, that's redundant. RPM is revolutions per minute. Has to go exactly 100 times. So what you get to do is you get to take and turn on your rotator and count how many times it goes around in a minute. The easiest way we found to do it is you take a pencil or a pipette and hold it up against it, and every time it bumps the pipette, 1, 2, 3, 4, 5, and you get a count for 1 full minute. The other piece about this is the other piece of QC we have to do is we have a dropper bottle, and you have to count how many drops come out of the dropper bottle. You have to have exactly 29 per mil. So you have to drip out exactly the amount, no, it's 50, and then make sure it works. What you're going to look for is you're going to look for what it says looks like black pepper. It's going to have little agglutinations. Again, the background's going to clear. If you have a negative reaction, the way you're going to be able to tell that is when you swirl it off, it's going to get a tail on it. It's going to have a tail. If it doesn't have a tail, you got to look closer for agglutination.
Couldn't you just put it on a centrifuge for 100? Or not?
No, no, it only goes 100 RPM. Most centrifuges go thousands of RPMs. And we've got it on a card. It's not in a tube.
Oh,
Yeah, it's on a card. This is our our control cards, and I think I still have some of these in here. But see, this is what a reactive looks like. This is a non-reactive, and if we were to swirl it, you'd see this kind of comes off as a little tail as it's going around. This is a minimal to moderate reactive, so it's got a little bit of fuzzies in there, it's a little bit clumpy. We report it as reactive, weakly reactive, or non-reactive. Once again, we don't report this one as negative. Serial to dilute out any reactive or weakly reactive titers. So to do an RPR titer, I think there's 5 each. We have these wells. We have to run a reactive, a weakly reactive, and a non-reactive every single time we run the card. Okay? To do a titer, so what we would do is we just put it straight on here and run it. Okay. If it comes up reactive, we have to titer it out. What we do is we start with a 1-to-1. So in other words, if I have a drop, if I use straight plasma and mix it with reagent, I have a 1-to-1 dilution. I don't make these in little tubes and then put them on the card. I make them directly on the card. What I'm going to do is I'm going to put straight plasma here. I'm going to put, each drop is 50 microliters. So I'm going to put a drop of diluent on each of these. All right? Then I'm going to take my Eppendorf pipette, and I'm going to very carefully take 50 microliters of sample and mix it with this diluent, gently up and down, without scratching the card. And I'm going to take 50 microliters of that, and I'm going to put it in this one over here and gently mix it up with this drop. And then I'm gently going to mix it up with this drop, and then gently mix it up with this drop. So I'm going to have a 1-to-1, a 1-to-2, a 1-to-4, a 1-to-8, and a 1-to-16, right? Smiling up. I report RPRs as DILs, and the DIL is the bottom number. So if it was reactive here, it would be 1 DIL. If it was reactive here, it would be 8 DILs. Okay? It's only for RPRs. Don't ask me why. That's how we report them. Smile and nod, do what you're told. Okay? Now, if it goes out higher than 1-to-16, we have a problem with our test methodology. And the problem is there's not enough protein left for a substrate media for our stuff to react. So if I have to go further than 1-to-16, instead of using my diluent, I have to take and make a 1-to-50 dilution of a non-reactive patient serum and use that to dilute with. Because if I don't have the protein, the test doesn't work. So over 1-to-16, I have to use a protonated solution to dilute with. And that will be on the test, I can guarantee you. That question will be on the test. All right? So then what I would do is then I would take my 1-to-16 or make a 1-to-16, and then I would go 32, 64, 128, 256, and 512. I've never seen one higher than 64. That's the highest I've ever seen it go. I do know that at 256 we stopped. If it's greater than 256, you need a big old shot of penicillin. You need a nice bolus of penicillin to get this cleared up. We see false positives in a number of disease states. Lupus is almost 100% positive for Reagin. So somebody who has lupus will give us a false positive reaction. And as a matter of fact, that's who our greater than 1-to-256 was. Patient did not have syphilis, the patient had lupus, which served very nicely for a very long time because she was our control when we had to do lot number crossover and stuff. False positives are also seen in hepatitis, infectious mono, pregnancy. 100% of people who have leprosy will give you a false positive. Trying to remember some of the other lovely and exciting disease states that'll do it. Yes.
So you said you have to do the protonated solution because you ran out of protein from the patient?
Right. When we dilute it out with saline,
Yeah.
so the concentration of protein, which comes from our patient sample, by the time you've diluted it more than 1-to-16, there's not enough protein left to give you the viscosity in the specimen or in the test method for it to agglutinate. Because remember we talked about when you have agglutination methods, and that's what flocculation is. When you have an agglutination method, if it doesn't have enough protein, it won't agglutinate. Well, that's exactly what happens if I dilute it more than 1:16. So what I have to do is dilute it with a protonated serum. Yes.
So you said it reacts with lupus, so could that be a confirmatory test for lupus then too? Or is it only something?
It could be a screening test for lupus, but there's much better screening tests. Yeah. But yes, if you had it come up positive, lupus is definitely something that we know to investigate these days. And in fact, is lupus, well, again, I know we're creeping back up there in the numbers, but at one point lupus was more common than syphilis. Yeah.
So you still take the 50 microliters and add it to the bottom well there on the 32, but
Right,
you just use something else to.
Yeah, I find a non-reactive patient, somebody whom I've already tested and I know that they don't have syphilis. Okay, so I know that they don't have rion. I take that protein, or that serum, and I make a 1:50 in a test tube. And I use that to put my little drops down here. Okay,
Before you mix it with the patient.
before, yeah. So I take a tube and I make a 1:50 with a non-reactive protein, okay? And then I take and put 50 microliters here, and then take my patient, take a 1:16 of my patient, because not that anyone would ever be stupid enough to make a straight dilution on the bottom row. But you take a 1:16 and you mix it here, then take 50 microliters of that and mix it here, take 50 microliters of this and mix it here, 50 microliters of this and mix it here, and then down.
So the original 50 microliters was.
Straight, you put 50 microliters of straight plasma here, or serum here, which is our 1:1, which is what, we repeat the 1:1. We always repeat the 1:1. And then here you start with 50 microliters of serum and 50 microliters of saline. And mix it and then do your serial dilutions. We'll do one on the, I'll show you, I'll put it up on the Elmo and I'll show you how we do it. But the important part to remember is that with this particular method, we have to use a protonated serum for anything greater than 1:16. Otherwise, the specimen's not viscous enough for us to get a reaction, even if it is positive.
Originally the patient was providing the protein.
Right, the patient provides the protein all the way out through here. Well, once you've diluted it past 1:16, it's not got enough protein in it to keep going.
Are we gonna do it after that?
Yes, we're gonna go do our beers. Exciting, thrilling, woo! The VDRL we're going to do on spinal fluid. We use a glass slide with a depressed well, add the antigen to patient specimen, and let it rotate for 8 minutes. And we're going to read it microscopically. I swear I'm going to bed tonight. VDRL cardio. The thing with the VDRL reagent is the VDRL cardiolipin antigen does not contain the charcoal. Our cardiolipin agent for our RPR contains the charcoal, which is our visualization. And this is a positive VDRL. Again, you will never do this test. If you work at a really obscure lab somewhere, or you go overseas to work in an underdeveloped country that doesn't have facilities, that's about the only reason you would ever do this. This is just not a test you do. And as a matter of fact, anymore when they order a VDRL, we automatically change it to an RPR or to PCR. Yes?
Something negative for 1 and 2 and then a positive?
This is a negative. You can't really read these either. This is positive.
But that's the 1 to 1 dilution is an alkaline.
Right.
And then the 1 to 2 is a negative, and then the 1 to 4 is a
No,
positive?
this is different patients.
Okay.
These are different patients. This is a negative, these are positives. Okay. This is an indirect fluorescent treponemal test. Okay, what we do there, this is our sandwich method. Okay, We put the T palladium, this is what they look like, aren't they cute? We put those on the slide, and we look for the antibodies. Okay? Oh, sorry, this was that was the directory. So we got the little T palladium, patient antibody that's labeled with fluorescein dye. Newer syphilis test methods, particle agglutination tests have replaced microhemagglutination tests, i.e. we don't do the VDRL anymore. Enzyme immunoassay, we can do a direct immunoassay for Reagin or for IgG or IgM treponemal antibodies. So I can do an enzyme immunoassay for syphilis IgM antibodies and for syphilis IgG antibodies. PCR can isolate and amplify the specific sequence of DNAs. It can be used on either serum or spinal fluid. Most commonly we use it on spinal fluid. Why wouldn't we use it on serum? It's an expensive test. So we can collect all the serum we need. Spinal fluid, we try not to do those any more than we have to. It's very, very sensitive, very, very specific, but it's also very, very expensive. So if we think that the treponema is in the spinal fluid, it's worth the expense and to do this. There are much cheaper and much simpler tests if we're using serum. Yes.
You're not gonna do the RPR, you can do an EIA kit, right?
Yeah, we still did do RPRs until it actually went on an analyzer, simply because it is very cheap, and actually it's better. It's got a better sensitivity than do most of our EIAs.
Does the EIA only report positive or negative and not the?
It can do either. We can have either a qualitative or a quantitative. But the Reagin test was still very sensitive. It was better than a lot of the EIA tests that were out there. Okay. Yeah, it's an old fart method, but it worked and it still works. It's just labor intensive. And so anything that is labor intensive is being replaced simply because people are expensive, machines are cheap. Relatively, yes.
Is the PCR trying to amplify DNA from the Reagin or the syphilis?
From the syphilis itself.
So then,
When we're doing this, we are looking for specifically for the organism itself.
so didn't you say it is in the CSF?
It would be in, the bug itself would be in the CSF, in secondary and tertiary.
So why would you even do the serum?
Why would we do
Why
what?
would you do the serum if it's only in the CSF?
No, it's usually in both.
Oh, okay.
Yeah, it's in both.
Okay.
Okay, the second common, semi-common spirochete disease is Borrelia burgdorferi, or Lyme's disease. It is fairly common in the U.S., especially western Colorado, that area, and up in the northeast, Virginia, West Virginia, some parts of New York. Not all of New York is New York City. So upstate New York, Pennsylvania. It's a spirochete transferred by a deer tick. It is the most common vector-borne disease. What's a vector? You know what a vector is?
A host? Or someone that transfers
An
it?
intermediate host, yeah. In other words, the life cycle of this little dude, you can't get it, except for a blood transfusion. I can't give it to you. It has to come from me to a tick, because part of the life cycle takes place in the tick, and then the tick gives it to you. A vector is something that's required as an intermediary, just like malaria is, the vector for malaria is the Anopheles mosquito. Okay? You don't get malaria directly from somebody else, you get it from a mosquito bite. What we see is a bullseye rash. It can go to central nervous system and cardiac involvement. Most commonly, it presents as arthritis. And the initial most common symptom is just dead ass tired. I'm so tired, just sleepy, exhausted, fatigued. You can see skin or nervous system in the early stages, but then it settles down and just becomes an ungodly arthritis.
The health teacher at Swick, she was the face of Lyme disease in St. Louis, and like they had like she was like in the newspaper, the front page and everything.
She had it.
As like a kid.
Yeah, it's not actually uncommon, but again, penicillin. But the hardest part with Lyme's disease is figuring out that's what it is. Once you figure it out, treating it's not such a big deal. But figuring it out and putting two and two together, because we don't have a lot of Lyme sticks in this area. So, yes,
I thought it had like huge neurological symptoms too,
it can. It can,
like syphilis.
like syphilis, yes. About 60% develop neurological symptoms as well. Unsteady gait, tingling, numbness. Antibody detection is the most common ways we do this. EIA. We do EIA more than IFA simply because it's cheaper. Okay. We can do a direct antigen detection method by PCR. You can get a false positive if the patient also has syphilis. Okay. You can get a positive RPR if the patient has Lyme's.
Is the
What's that?
I would say, is the bullseye rash just an initial, or does that stay?
That's in the initial.
Okay.
And I'm not sure on that. I think it's at the site of the bite.
Yeah.
I think that's where it begins. It would be my guess.
But it goes away.
But it goes away. Yeah. So, and it's one of those things you may not develop symptoms for a couple weeks after you got bit, or maybe even a couple months. So it becomes finding it and identifying it can become a problem. There are other spirochete diseases. The reason we only really talk about those two, those are the only two you're likely to see in central Illinois or anywhere in the Midwest. You're not going to see leprosy. You know, you're not going to see a lot of the other disease states that are caused by spirochetes. So those are the two we talk about. Keep in mind, they are not the only two spirochete diseases out there. There are others. They are simply the common ones that we deal with in this area. All right, questions, problems, complaints? All right, why don't we do this? I don't want to do viral diseases today. We're getting ready to go do RPRs.
Well, I talked to Mr. Panglandina, and I know why my scope is acting up, because the bulb is going out. So I only got about a field this big.
Oh.
But I still could show a few patterns for real, so they could see what we mean
Okay.
by the A&A slide. And I
Okay.
got the kinetoplast on right now. You gotta look at, it's the right eye.
Yeah.
Because I was doing the right thing yesterday, and I called him, so I was doing the right thing. But could I show him a couple
Please.
things before we go?
Sure,
It's a real quick thing, and then I'm gonna email this to you. And then that way,
Perfect
when you
timing.
come over, when she gets you going, I'll just take a couple at a time and at least try to show you a couple patterns for real under the scope. But I found this really good sheet that kind of gives you what is the anti-nuclear antibody associated with each disease and what pattern you may see. Okay, so I want to give you that first, and then I'm just going to show you, I have a little seven slide PowerPoint of what we'll try to be looking at. Because I was a little disappointed their new slides didn't have all the patterns. So you take each one of these, and then let me just pull it up real quick. That way, when you come over with me, you'll have an understanding kind of what I'm talking about.
Well, I'm gonna get syphilis stuff out.
Oh, that'd be great. A&As are so interesting. When I was in serology, one of my jobs was to do chlamydia, which was under a fluorescent microscope, and anti-nuclear antibody testing. So for your lupus, your rheumatoid arthritis, even I just found out Chanel at St. Joseph's in Breeze has Sjogren's, and she not only it affects all your secretions with dry eyes and everything, but a lot of joint pain and inflammation. So that seems to be a very common theme of anti-nuclear antibodies, that you actually have a lot of connective tissue or collagen disorders. So I wanted to just show you this PowerPoint I made, and I'll send it to you guys because I can't get the whole field. So I forgot he had told me when he did the scopes that the bulb is going out. That was donated to me by St. Joseph's, and I've been using it probably 10 years on the same bulb. Usually a bulb has like 200 life, time, but I always thought ANAs were so fascinating when I did them, and this one pattern I just absolutely love called the centromere pattern. So this is what I'm trying to show you, okay? So you can see when we get to the 5 different patterns, what I've tried to show you is then what specific anti-nuclear antibody would be associated with what disease, okay? So our job as a tech was to report the titer and the pattern, and then if it was over 1 to 80, then the physician would have to send it out to a lab that would do each one of these specific anti-nuclear antibodies. And what's cool about it, Christian has the double-stranded DNA test, and it looks for this parasite called Crithidia. So that's what I have up at the scope right now. I didn't want to it was hard for me to find it anyway since I only have right field of the view. But I always thought these were so interesting. And they started using this HEP2 cells, human epithelial cells, and you're only looking for the antibody to attack something on the nucleus. So all of these that fluoresce with the FITC, so with syphilis, the FITC is this fluorescein isothiocyanate. It was what fluoresced when we did syphilis testing. If your RPR is positive, we always then did a test called the FTA. Well, and the other thing we used, the indirect fluorescent antibody test method, was for ANAs. And this green, apple green fluorescence is what that FITC, that tag, just like latex does the white clumps, the FITC is a fluorescent tag, and it does this real pretty apple green. So they don't have 2 of my favorite patterns. Well, my favorite pattern is centromere. And on their slides, they gave me 4 slides and they don't have that pattern. But the homogeneous, so we'll get into the field, and these are the nuclei that are fluorescing. So if you look on your sheet, and I give you both sides where you can see the pattern with what disease they have. When they say antigen, you will make the antibody to that. So there's an antibody to double-stranded DNA, goes with diffuse or homogeneous. So they chose at Christian to not send out everyone, because if a lot of people have lupus, they'll catch them at Christian and they can save them a ton of money and not have to send this out. So if I reported a very high titer, greater than 1 to 80 of this, then Christian then would do a test called the double-stranded DNA. They would take one of these anti-nuclear antibodies, and if it shows positive, which that's the last slide I have on here, then they know they already have lupus and they don't have to go sending it out. It is a very costly test. Yes?
Sorry, what is your specimen?
Serum? Oh yeah, it's just serum. It's easy. It's a pretty long process. When I first started doing these, and I could probably do it in my sleep, and I probably haven't done it for 15 years. When I first started doing them, you didn't use human epithelial cells, they probably used mouse kidney. And we couldn't even detect one of them called systemic sclerosis with this CREST syndrome. Then they started using these slides, and you can do 12 wells, and you can titer multiple dilutions, And then you can put all the dilutions on each of their own little well. And in one test, you can give them a titer, you can give them a pattern. And the one pattern, this new methodology with HEP2 cells, human epithelial cells, you could identify if they had this one disease called, it used to be called scleroderma with Crest syndrome. Now it looks like it's being called systemic sclerosis. So that pattern wasn't even detectable, the first methodology. So that's how you use this chart. You see the pattern. This, you can't hardly see the outline of the nucleus. These are all kind of like nucleoli in a blast. These are the nucleoli in these HEP2 cells that fluoresce with this FITC. So if you look at nucleolar pattern, you would see it goes with lupus and the new thing, progressive systemic sclerosis, the PSS on the one chart. I think on the back chart it calls it nucleolar lupus or scleroderma. So the scleroderma is more the old terminology, but they're one and the same. Then if you look, there's just little speckles. The centromere is a really cool pattern that has speckles too. But if you, the speckling pattern in all these nuclei, they're not really a uniform speckling. So when we first started using HEP2 at St. E's, Dr. Ramos, our pathologist, was the one training us. And he said, in time, you will be able to identify a speckled pattern called centromere. But I never called it unless I saw these mitotic cells. And I'll show it to you when we get to that pattern. I was not going to call because that told them you were being diagnostic as the tech if you called centromere pattern. So I was determined I was never going to call one without seeing these mitotic cells, not just speckling. So this is a true speckled pattern, but when we get to the centromere pattern, it has speckles too. I probably have never called a rim where the FITC fluoresces on the rim, but if you see the rim pattern, it's called peripheral rim. It would go with the DNA and with lupus. If you look at this chart, lupus can have almost every pattern except the centromere. That's predominantly going to be your disease state you're worried about when the doctor orders an anti-nuclear antibody test. And then this has always been my favorite pattern. Once I got good at it, I could tell that the speckling was different. But I never called one unless I had all of it lining up in the center of the nucleus. And so once I started getting to understand this speckling that came with centromere, then I would start looking for those little mitotic nuclei that would all line up across the center. And so this is diagnostic. If you call centromere pattern, they know they have scleroderma with a thing called Crest syndrome. And then, so those are the 5 patterns, and they used to give me one, and this new one, they gave me a nucleolar, a homogeneous, a speckled, and this is the confirming test for what Christian does. It is the coolest thing. This is a parasite, and everything that is fluorescent on this parasite called Crithidia is called a kinetoplast. So I never in my career got to do that at St. E's, but at Christian, they taught me how to read them when they knew I had a fluorescent scope and wanted to show the students. And so they would start giving me, and the 2 slides they gave me, these are only the positive control. None of their patients on the slides. And these are, I think, 8-well slides. You can get slides that are 6-well, 12-well, 8-well. And then we would do them every other day. Some labs don't do them every day because it takes, you're probably going to tie up a couple hours of tech time. You have incubation periods where you go do other stuff. But I always love doing the fluorescent microscope. So I don't know if any of you will get exposed to it, but I always thought it was the coolest thing. So that I thought is a little bit of a little cheat sheet for you to understand. We do a general ANA. These are the specific anti-nuclear antibodies, and these are the patterns and diseases associated with it. So the one thing I thought was really interesting just on the one that's the centromere pattern, the one before that, it now is called limited. It's called, what used to be called scleroderma, it's now called systemic sclerosis. But when it has this centromere pattern, it's called limited scleroderma, sometimes called Crest syndrome. They have calcinosis. Have you ever heard of Raynaud phenomenon? With multiple myeloma, sometimes people get issues with cold in their extremities. The people who have scleroderma with Crest syndrome get this. They can have trouble with their esophagus, so probably affecting their swallowing. And they have telangiectasias, which, remember, those were lesions that bled in hereditary, and it was involved with the vessel. The other thing I thought this was interesting, with this one, there was something good that I wanted. It may only affect skin in the early stages. You may see skin thickening and shiny areas developing around your mouth, nose, fingers, and bony areas. You may have hair loss, calcium deposits, that was that calcinosis, small dilated blood vessels under the skin surface, joint pain, shortness of breath, dry cough, diarrhea, constipation, difficulty swallowing, esophageal reflux, and abdominal bloating. So none of these are good, and none of these are probably easy to treat. A lot of time it's steroid therapy, but it's always been one of my favorite things I got to do as a tech. I'm kind of a fan of the doing the work and not putting it on a machine. So I luckily in my career got to do a lot. That's probably why I like TIFFs, and I love doing manual tests so I could actually affect the result because of my quality of work. So I hope, in your career you sometimes get exposed to the fluorescent microscope. Yes?
What in the centromere pattern, what's making some of them speckled and some of them light up?
I don't really know what is triggering. It's the mitotic piece of that. I'm not sure what triggers that in the pattern. It's just the feature of it. I don't know why the speckles line up like they're in mitosis. But that is, for me, like Dr. Ramos told me, you're going to be able to pick it out even without seeing those. But for me, I felt better since it was diagnostic, not calling it unless I saw them. But I'm not really sure why some cells show that and some don't. But that's really all it is showing. So I'm going to be in my office. I'm working on your contact times for your clinicals. And I have to laugh, you guys. Email I just sent. The only way I found out I sent it wrong last night was I was calling one of my students from Sparta to see to come to my meeting. And she said, "Do you know you sent it to us?" So last night I sent that email to my last class. So I guess they were all anxiously, they put it on Facebook that they're going to have to come in and take my UA final. So thank God Robin told me. I wouldn't have known it and went to the wrong. I went back to my sent emails. There it was, Daniel, Robin. So thank God I talked to Robin. Okay, so if someone, when you guys get going on that, and she's ready to have some of you, I left the kinetoplast up, so that was my